Welcome. Today for the Mastermind group, our third one in the series. Today we have our dentist, John Fluke, and a dental hygienist, Alyssa Aberley, who are joining us. And I gotta tell you guys, I am really excited about this topic. And the reason why is that the ADA said that dental insurance concerns are often rated as the most important concerns in a dental practice for dentists. And I'm like, why? So can you give us your opinion on why that might be such a pressing issue?
Hmm. Well, it's a pressing issue for dentists because in some parts of the country, it's a pressing issue for patients. And, um, one of the things I have to give the dental insurance companies a great deal of credit for is they have managed to somehow convince the buying public that if insurance doesn't pay for it, it's not necessary. Or I'm amazed how many people will, I call it fall off the dental wagon, where they disappear for 2 or 3 years. And Alyssa, I'm sure you hear this too as a
Oh,
dental hygienist, where they come back in and then they're like, gosh, I know I haven't been in for 3 years and my mouth is a mess, but I didn't have dental insurance.
hmm
And I look in there and I'm like, well, I understand you probably would have had a couple $100 out of pocket every year, but you're going to have 5 or 7,000 out of pocket now, because you've fallen off the wagon. And that, I think, is the reason, is that the insurance companies have managed to uh, make the patients think that dental insurance is the end all be all of care. And we need to, through the educational process, win people back from that.
yeah, I would agree with that. I think you'd have coverage for patients and then low and not low reimbursements for dental providers, but also not increasing with the cost of living. And so you're kind of stuck in this conundrum where dental providers feel like they're in they're stuck. They can't charge any more than what they've contracted with the dental insurance, but cost of everything else, salaries, supplies, everything is going up. So everyone's kind of stuck in this mud.
Yeah,
And I,
was it in the 1969 or 1970, some survey, and the yearly like maximum out of pocket benefits were $1,000, and magically now in 2021 the
Still,
maximum out of pocket benefits is $1,000. And call me kooky, but $1,000 went a lot further in like 1970 than it does in 2021. So
you
yep.
don't say. Well, what about also with the PPE, more
yeah,
costs, it seems. Are reimbursements being cut back or are they changing because of, the current situation?
they're not cutting, at least I haven't seen anybody cut back, but I haven't seen any extra reimbursement
Yeah.
for PPE. I don't know, Alyssa, how about your practice? Is it the same
Yeah, I
way?
mean, I know there are people that are trying to bill insurance for PPE, and some are successful and some are not. But I think you look at here in Colorado, we have had a minimum wage increase recently, and that conversation is happening around the country. Well, as minimum wage increases go up, so do all of your office salaries. So your dental assistants, your front office staff, your hygienists, the dentists themselves, but the reimbursements are staying the same. So if you're still only getting, you know, 30 or $50 for an adult pro fee, but your salaries are reaching 60 to $70 in some cases when you look at all your staff included. I mean, that alone, just that math doesn't work. That equation doesn't pan out in the end.
I saw actually today, I saw a tweet from the California Dental Association where they were encouraging dentists to get behind, and I can't remember exactly what it was, but it might have even been a piece of legislation to force dental insurance companies to provide for some PPE coverage. And I said, I may not have that quite right because it scrolled by on the screen and I was trying to read it and I was between patients, but it was something along those lines. And I don't think that's necessarily a bad thing. We've had PPE increase, I mean, through the roof since we've gone to the pandemic. A level 3 mask doesn't cut it in my office. We're wearing an N95 and level 3s over the N95s and among other things that we're doing, but just the cost of masks alone has gone up astronomically.
So true. Alyssa, are you sometimes caught in the middle between what a recommendation might be from the dentist or the specialist and what the patient is thinking, oh my gosh, I can't afford this, or oh, wait a second, I have insurance, but I'm not quite sure if my insurance covers this.
I mean, in hygiene, that's my daily life. I feel like I work in a federally qualified health center, so I see a lot of Medicaid patients, but even with Medicaid, I mean, I had a patient today who very, very obviously needs scaling and root planing, and Medicaid denied it because they say there's no evidence. But I mean, what are you to do? Because we don't operate like medical where we can bill based on our diagnosis codes. We're very procedure code based. And so you change your procedure code, you're also implying that you're changing your diagnosis. And so, but the patient's in a conundrum too, because this is what they need. And even if they want to do it, now they have all these out-of-pocket expenses. And you see that all the time with, root canal versus extraction. So many people would rather get an extraction because their insurance isn't going to pay for a root canal and crown, or they hit their $1,000 maximum, which isn't going to cover that. But they know that that's not the best treatment for them, but they say, well, that's what my insurance will pay for, so that's what I'm going to do. And so, yeah, back to the patients feeling like that's their Bible that they have to go by, is what their insurance coverage will be. I often encourage my friends not to get dental insurance, especially if they're somewhat healthy, because what they're going to pay in premiums throughout the year is more than what they would pay if they just paid out of pocket for their costs. So we get that all the time.
You're also talking to someone who in the last 2 weeks have had 2 extractions and implants are coming. So without health insurance, because I don't have any, that's $10,000.
Yeah.
And it's startling. So every time you evaluate the option for dental insurance, that kind of weighing out whether or not it will benefit you or what your circumstances.
Yeah, and you look at things like, well, implants, for instance. I've had people in my practice where they're in a similar situation, Lisa, where they're losing the first molar on each side on the lower, and you look at them and you say, look, really what you need is implants. I don't want to have to prep the second molar and the first premolar and put a bridge in there, because in some people's cases, you've never even had a filling on any of these teeth, and I hate to just sacrifice those teeth because when we could do a bridge and we don't have to do that. And I've had people over the years say, I don't have the money for the implants. I mean, I understand what you're telling me. And I think in a perfect world, that's exactly what I would do. But I have to do what's best financially. And so you're going to have to, prep these teeth for bridges. And as a dentist, that's a tough thing to do sometimes. There's nothing as good as what God puts in there at the factory. And it's hard sometimes to grind down perfectly good teeth because it's a financial decision for the patient sometimes, and that's unfortunate.
That's a real honest comment, because I don't think people realize that even dentists have to deal. I mean, it's an ethical thing of like wanting what's in the best interest of your patient, but these other factors that you have to play a role in. And I guess it would also be frustrating if I was a dentist to have an insurance company kind of second guessing me or questioning sometimes what is the best method of treatment.
all the time.
Yep.
All the time, not just
Yeah, that's very frustrating when, I think it's funny that as a clinician, if somebody came to me with a picture of a patient, for instance, which is what a radiograph is, an x-ray, and they said, make a diagnosis based off of this picture, that's malpractice. I legally have to see the human being, but the insurance company doesn't have to. And they make the they say they don't make the diagnosis, but I mean, let's be real, it's just semantics. They tell me that, that this is unnecessary treatment, or that another treatment that is, $5 versus, whatever is the better treatment. They're making a diagnosis and they're practicing dentistry, but somehow or another, magically, they really aren't. And I don't understand where that line is, other than they have a lot more money to lobby than I do.
Yeah.
But do you think also sometimes when there's delays with payment or with getting approval, that it's a game, or it's just, or maybe that there's policies? Because not just with dental insurance, I've seen this with, other types of car insurances or health insurance. Is there a process possibly where the goal is to deny or request more information? Could you send more reports or take a look at this?
I think you can, seriously, I think you can draw your own conclusions. That I'd like to know, Alyssa, because you work in an FQHC, do you see those kind of things with where you practice? Does that happen? I'm kind of curious because I don't know much about the internal workings of the FQHC world.
Yeah, I mean, it's similar with coverage. I mean, we do have options for patients to, get on a sliding scale if they don't have insurance, which in some cases ends up being a better option for them. Because Medicaid also has like a cap each year. I think it's like $1,200 currently here in our state. But they're very specific about what they will and won't cover. I think one way that I think our dental system for sure is failing is we're really putting emphasis on emergency and late treatment and losing our focus on prevention, which I mean, there's hundreds of studies out there that show that prevention is better for the patient. It's better for your practice long term because you keep patients, in your practice, but it's also better financially for the insurance companies. And I feel like dental just is still behind on that. For Medicaid patients, for instance, for most states don't have an adult dental benefit for Medicaid. So they'll cover kids until they're 21, but once they're an adult, they're not covered anymore. And so, but they will cover emergency room extraction of a tooth. So it's more beneficial for the patients to wait till it gets to the point where they have to go into the ER and get a tooth extracted in the ER rather than coming in for routine dental care. I mean, we're missing the whole boat.
Yeah.
So I feel like, and I see the same thing with private insurances too. I feel like we're nitpicking some of the earlier treatment in exchange for later extractions and more costly treatments, partials, prostheses, like all these things, when we could have stopped this process earlier and provided better care for the patients too. So yeah, we're all in this game.
I love this. This is a story that a friend of mine, actually, he was the subject, or the one that told me this. So they were trying to get something paid for, and it was the game of, oh, send more documentation. Oh, we need more documentation. Oh, that person is out of the office today, and so we're going to need more documentation. And they finally packaged up the documentation that was required, and they sent it to the insurance company with a return receipt from the post office. So they got the receipt back and they called and they said, oh, we're going to need more information. We don't have this, whatever it was. And they said, well, we sent that to you. Well, we don't have it. And they said, well, we have this return receipt from the post office. And the reply was, well, who signed for it? And my friend was like, well, we can't really tell because whoever signed for it just put a squiggle. And they said, well, we have all our mail delivered to a post office box and then a courier picks it up. So that's probably the courier's signature and the courier probably lost the claim. So we're going to need you to resubmit all the information. So, how much better can you get? They lose electronic claims, for God's sake.
Mm-hmm.
How that happens, I don't know. But it happens.
It's an interesting dilemma. But so what would be like a variable to make you guys decide, well, I will be on that insurance plan, or we will or will not accept certain dental insurances, or how does that work in a dental practice?
It's basically, for me, it's profit and loss. I've got to look at, can I provide the standard of care to my patients that I require of myself? And can I make a profit while I'm doing it? Because I like to say, you can be the best clinician in the world. You can have the best hands of anybody, but if you can't stay in business, you'll never help anyone. And so it becomes a situation of, if I'm going to lose money doing treatment, I can't do that treatment. I can't do that and stay in business. And from the other ethical side of it, I ethically can't do that to my family. I can't give my family's money away just because. I can't do it. So it's for me, it's all based on P&L.
And I think that's where it comes back to what we were saying before about patients feeling like they can't go to the dentist if they don't have insurance. Some of the insurance companies, their reimbursements are so low, or the procedures they cover are so limited, that there's very few offices will actually accept that insurance. And so then sometimes those patients with coverage are actually having a harder time getting access to a dental office than if they just didn't have it and weren't so tied to just finding an office that accepted it. So that's hard too, because I see patients that have coverage, but it doesn't cover very much, or it's not accepted by very many offices because of the reimbursement, and they actually can't get care even though they have coverage. And so that's a hard situation to help somebody through too.
And it's tough too. You'll have someone come in to your office and, with a child, and you'll do a child prophy, and then you'll ask the parent, well, do you want us to give him a fluoride treatment? Well, is that covered by insurance? And, interestingly enough, if it is, they'll take it. Usually if it isn't, they won't, even though we try to explain to them, but you don't understand, if you get a cavity, which is, much more likely without a fluoride treatment, you're going to have a lot more out-of-pocket expenditures, doing a filling, plus all the other wonderful things that go with dental treatment, and a child. But a lot of folks, it's dictated by, if my insurance company doesn't pay for it, then I don't want it.
And I think I think it really probably comes back to the American Dental Association and whomever else, but 50, 60, 70 years ago, there were ad campaigns about going to the dentist twice a year. And I think it came back and bit us, because now that's what insurance companies will cover.
Yes.
Even though that's a pretty arbitrary number and really doesn't have much evidence to support it. I mean, we see patients all the time that some should be coming in once a month, some should maybe once a year, and everywhere in between, based on whatever their risk is for caries or for periodontal disease. But we have gotten this in people's head that it's twice a year. And so anything outside of that just seems like you're trying to get money from them, when really there's a lot more evidence to support that than the twice a year mentality.
Yeah, Alyssa, I believe, if my memory serves me correctly, it was, I don't even know if they're still in business anymore. It was a toothpaste ad. And I'm going to say Colgate just because they're a toothpaste company. I don't know if it was them, but it was like Colgate twice a day and see your dentist twice a year. And
yeah, I can picture the ad that I've seen that was played on TV, but I'm sure
It was, yeah, but you're right. It was like
Yeah.
60 or 70 years ago that it was, whatever it was, twice a day, and see your dentist twice a year. And magically, then the insurance companies managed to pick up on that. And yeah, and that became the
Right.
standard.
Right. When that's very arbitrary. And
Yeah.
I mean, if we look at ourselves more like medicine, like the healthcare system, I mean, a lot of the things that we're treating are chronic diseases, and we're not treating them that way because we're treating them just like surgeries. Everything's a surgery, everything's a procedure instead of actually managing chronic conditions. And so some of it, I think, our profession created itself, but some of it is external, and we're trying to figure out how to provide the right care within those limits somehow.
Yeah, I mean, you look at things like periodontal disease and diabetes. They're very similar in that they actually affect one another. And if a physician has a brittle diabetic patient, they might see that patient once a month to evaluate them. But if we have that same brittle patient and they're subject to periodontal breakdown, at much greater risk than, your average patient, oh, no. You can't dare see that patient on a more frequent recare schedule, at least to be reimbursed.
Right.
They can come in whenever they want to, but, me, the insurance company, I'm certainly not going to compensate you for that. And yet it's been shown that people with periodontal disease, there are greater problems with diabetes, and people that are diabetic have contributing factors that contribute to periodontal disease. It's a catch-22 on that. And yet one way we treat it like a disease, but in the dental way it's treated like a procedure, which I agree with Alyssa 100%. It's crazy.
The separation of dental and medical is part of it, but the separation of dental and medical insurances is the other part, because the dental insurance is basically just pushing those costs off on a different insurance company, because that patient's most likely going to have complications from their diabetes at some point because they're not getting full management of their condition, but now it's somebody else's problem, I guess.
And even if you have the coverage, so many years ago with TMJ, I had a medical coverage for it, but even the TMJ specialists are like, good luck getting access to it. And literally it took a 3-hour marathon of being transferred from department to department. We're finally, and I don't cry, people, but I just broke down crying. I mean, the frustration when you cannot work a system and you have the benefit. And some poor lady said, you know what, honey, just send it to me. It's not my job. I'll shove it through. But it should not be that difficult if you do have medical coverage for, a pain and a medical issue.
Yeah, I mean, we see that all the time. Like you mentioned, diabetes, sleep apnea, heart conditions. I mean, there's a lot of things that are connected. And if we could somehow bridge that gap between both dental care and healthcare, medical care, but then also in the payers, it would be a huge benefit.
That is so true. Well, what about waiting periods? So I understand sometimes there's time frames that you have to wait because the insurance company is saying, time has to pass before you can continue with a dental procedure.
Yeah. There's waiting periods on we won't pay major for like 2 years. My personal favorite is the missing tooth clause, which basically states that if the patient's tooth was gone before we insured them, then we don't have to fix that missing tooth.
Yeah, it's basically like a pre-existing condition situation. But your pre-existing condition is that you are missing a tooth and can't eat. So
so tough. And this literally, this is a great story, happened to me, called the insurance company. And I was trying to get coverage for this gentleman. And I said, so I can't get coverage for this gentleman because this tooth has been missing, for like 5 years, and he's only had your insurance for 3 years. And the lady was like, right. And I said, but if I were to just randomly extract a perfectly healthy tooth, then you would replace that tooth and this tooth. And she said, right. You know, like I'd solved the Rubik's Cube or something. And I was like, I don't know, you have a, you're missing your right foot, and we won't pay for a prosthetic, but if you just randomly cut off the left foot as well, then we'll pay for both. I mean, there's just, and I'm like, and there's logic in that. How? Tell me how that works.
They don't want to pay.
Yeah,
Yeah.
they don't. And so you do see things of, oh, well, you're going to have to wait 2 years for major coverage. Somebody shows up with a crown, and maybe for, a number of variables, there's decay around the crown. And, we look at them as a new patient, and we say, well, you're going to have this crown redone. First thing the insurance company wants to know is, when was the crown done? What year? And then what month, because we're only going to pay for it if it is older than X, but I'm not going to pay for it otherwise.
And that's, I mean, I was talking to someone in my family about this with like let's say you get your knee replaced. Well, there's a percentage of patients that their body doesn't accept the knee replacement, right? It rejects it. They have complications. Doesn't mean that anyone did anything wrong.
Right.
It just means that for whatever reason, there were other factors that made this knee replacement not work. Well, same thing with dental care. You see all the time, there's a crown or an implant or a filling or something, and it just doesn't take. There's a lot of external factors, like we said, a lot of health factors that can come into play. And so sometimes you either need to replace it or you need to come up with a new plan for that area. Well, like you said, you can't until it's been 5, 7, whatever the arbitrary number of years it is. So then what ends up happening is, again, patients get teeth extracted that don't need to be extracted. Patients can't eat. I talked to a patient the other day who has diabetes. I was in our medical clinic and I was seeing her, and I said, well, are you able to eat? And she says, no, I just eat yogurt. And I said, that's all you eat is yogurt? And she said, well, that's all I can eat. I can't chew anything because I'm missing all these teeth, and my insurance won't pay for me to get a partial. And I'm like, well, that's not good for your diabetes. Like, you want to talk about what's not good for your diabetes is not having nutrition and probably eating sugar-filled yogurt. So yeah, there's a lot of things there that don't make sense and don't connect.
Well, are the insurance companies doing, I think they called it virtual credit cards or payments using credit cards to I wasn't quite sure when I was, preparing for tonight,
Right.
what that was and how common an issue of virtual credit cards are in payment.
I don't think it's very common, because this is the first that I've heard of it. Now, I will say this: the business piece of this, the taking of the money and the processing of the payments, is not what I do. But this is the first I've heard of. I mean, I know there's things like Care Credit that
Right.
people can use to pay for things, and that sort of thing. But this is the first, Lisa, that I've heard of a situation. Have you heard of this, Alyssa?
No, that's what came to mind was Care Credit to me
Yeah.
too, was something like the insurance isn't going to cover it, but you can apply for basically a credit card financing option for your dental care, but interest is pretty high. A lot of patients don't really understand exactly what they're getting into financially, but I mean, it is an option for patients when they're kind of out of options. But
So what can we do? I mean, when you think about, because when you guys were talking, what I do some volunteer work here in Cleveland, and when they have dental clinics, it's like mission work.
Sure.
Called MedWorks here in Cleveland. And when they have those dental clinics, and it's a tremendous support of dental professionals who come out to be able to meet the needs of the community, a lot of it is teeth removal and people in pain. And when I've volunteered at these clinics, I've been amazed at how so many people, or even as Alyssa, you were saying earlier, it gets too far and then you're having teeth removed and then there's no finances to be able to, assist for them with eating and all that kind of stuff. It's a problem.
It is. It's a problem, and it's unfortunately a problem that I think is going to somehow require government intervention. dentistry's been trying to change this, for years. And the ADA, God love them, they've got an incredible lobbying, reach, and they try and do what they can. But I think until our federal government actually begins to look at this and realizes the amount of money that is wasted because we aren't doing proper prevention, um, that there's just not, I don't think there's much as individuals really that we can do. Now, maybe I'm just old and worn out from the fight, but I mean, this was going on when I got into dentistry, and my hair was black back then, and it really hasn't changed much.
Yeah, I think that, I mean, there's a few things that always come to mind. Obviously, I'm a hygienist, so prevention is kind of my thing and my soapbox that I'll stand on. But I mean, like I said before, there's so much evidence in healthcare and in dentistry that prevention saves money. And I think if insurance companies start viewing it like that, and also viewing it as chronic care management rather than as surgery. But again, I think there's some of the stuff that's ingrained in our profession from a long, long time ago that we kind of have to break away from. Even like our CDT codes that we hold so tightly to. I mean, other countries don't use those. Those are just the United States. And so if we look at some other models of how people are billing for and documenting and getting reimbursed for their care, I think the procedure-based codes is hurting us. I think being separate from medical is hurting us because, like we said, there's a lot of interconnection, and we're not seeing that from the reimbursement side. And then I think, like we started it off, like you said, Dr. Fluke, just teaching patients that that's not the end all be all is their insurance. And, being able to break it down and show them that they're actually going to save money if they pay out of pocket and keep up with their care rather than waiting until they have insurance coverage that ends up not paying for much anyway. So I think it's a multi-step process, but yeah, I agree. It's not going to happen just us alone.
And I'll tell you, it frightens me is that both of my parents are approaching 90, and we are about to see our healthcare system is now so good at keeping people alive. We are about to see a wave, a tsunami of people that are going to require outside care to take care of them, whether it's nursing visits at home or nursing visits in a nursing home or whatever it is. And the other thing I want to get on my soapbox about is dental in those environments. And Alyssa brought up a good point, where she mentioned that we're separated from medicine a lot of times. And I remember when I was in dental school, we had a lady on staff at the dental school who was quite the artist, and she had this really cute cartoon where she showed it was medical school, and there was this person with this itty bitty little mouth and this huge body, and all these people were studying it. And then it said dental school, and there was this person with this itty bitty teeny body and this gargantuan mouth. And that's kind of almost how the two sides of this look at each other. And my father is in a skilled nursing facility, and there is very little attention paid to any kind of oral care in that environment. And we're looking at people only living longer. The baby boomers are now getting to the point, where they're in this phase. It's a huge population. I don't know, honestly, how we're going to take care of those folks, and they deserve the best we can give them. And I think that we need to look at more reimbursement from a teledentistry and telehealth aspect of things, of being able to send folks into these facilities with cameras and, take pictures of folks and maybe be able to, do some diagnosis and some treatment planning without actually physically touching the patient and some other things, because we're just not going to be able to go in and do what we need to do to keep everybody I mean, just quality of life out of pain, if nothing
Yep.
else.
Now you're speaking my love language, because I literally just got back from Orlando. I went to the National Mobile and Teledentistry Conference. First of all, I went to an in-person conference, which is amazing. But secondly,
3D, 4D people.
yeah,
Right?
real
Yeah.
people. But secondly, it was full of, I mean, there were dental professionals, healthcare professionals, technology company CEOs, and it was really just a brainstorming of how do we get this care to the people who need it? How can
Mm-hmm.
we, bridge some of this gap of interprofessional care where, yeah, teaching nurses in
Yep.
these facilities to be doing some of that information gathering, or having a hygienist go and really not taking the dentist out of the equation, but just finding creative ways to access those patients using the technology that we have. I mean, medicine has moved to telemedicine and is using it successfully. And how can we think creatively about how to get care to people? And then back on the reimbursement side of that, nursing facilities, in order to be reimbursed for the care that they're providing, they do have to provide oral. But a lot of them either don't know how or don't
Mm-hmm.
have the resources to do that. And so how can we, again, step over into the medical world and, work with our colleagues, nursing colleagues, medical colleagues, and, find ways
Yeah.
to help them provide that care. So yeah, I think it's all about thinking creatively. So
Do you think,
Yeah,
though, that
100%.
that's a direction that the dental world and the medical world will team up? Because, I mean, they're interrelated.
Yeah, I do think that. I think, if there's been one kind of silver lining from the whole COVID-19 pandemic, is I do think that that's kind of kicked off more of this telehealth, and I'll use that as, medicine and
mhm,
dentistry.
mhm,
Um, and I think people are starting to see on both sides of the healthcare equation now, medicine and dentistry, that we're seeing the availability of these kind of systems, and as Alyssa said, that they work. And I think it's a matter of spinning up people that are trained well enough,
mhm.
um, to get this process off the ground.
I think that's the part that's holding dentistry back from it, right? Is that, well, how can I fill a tooth over the phone? Well, you
Right.
can't, right? But there is a lot that you can do. So I think we always think like a patient sitting in their bed and you're in your office and they're supposed to somehow have you do a filling. But really, what works a lot in teledentistry is provider to provider. So you have, like we said, a nurse or somebody else, a dental hygienist, or somebody else who's trained to be able to take photos and radiographs and do a lot of that information gathering for a dentist or a mid-level provider somewhere else to be able to work collaboratively. And so there's a lot of provider to provider models that are available to us if we are willing to kind of walk down that road. So
Yeah, absolutely, absolutely. And the legal, I think, ramifications, they need to change some things that say situations such as hygienists can place in an emergency situation, or I mean, we could figure it
yeah,
out somewhere,
yeah,
that a hygienist could place like glass ionomer fillings that
yep,
release fluoride, and could, help these people, that you don't need to have a bunch of equipment and a bunch of extra
right,
hands, but you'd also, that's going to help that you don't have patients with big holes in their teeth either, and that's the
right,
kind of thing that I think we need to look at. And I could see a situation where a dentist could have, 2 or 3 hygienists on staff, have them each in a separate, skilled nursing facility, and you're looking at things and saying, okay, uh, Alyssa, your patient needs, let's put some glass ionomer in tooth number 3. Let's take, maybe some type of electric handpiece. Let's smooth the sharp spot off of tooth number 6. That kind of stuff. You could
right,
do that, and it could
yeah.
easily be done. You know,
Yeah.
I mean, Alyssa can put really sharp things in people's mouths already and handle them with a great deal of skill.
And they don't bite her.
Exactly.
Right.
Yeah. And I think she could probably, you know, do some procedures that would get our patients out of pain.
Yeah. So I think there's again, a multifactorial approach to
Yes.
solving some of these problems, but there are people out there trying to solve some of these things, and hopefully they can do a good job of documenting it and making it so that other people can replicate it.
Yeah.
Well, it's a wonderful way to wrap up today's discussion because first of all, you guys have gotten me excited about telehealth and teledentistry because I had no clue when I, as a layperson, would hear those words like, yeah, how's a dentist going to do this? But when you talk about provider to provider, oh, wait, I get it.
Yeah.
And from working in nursing homes earlier in my career as a social worker, I get what happens when those dentists are coming in and what could be done. So part of it is people to be thinking outside the box as we're surging forward with technology. As a result, I think, you know, you're right, John, the pandemic pushed technology forward in a way that is going so quickly, and it just makes sense that as we keep progressing and going forward with new ideas and trying things, that, you know, that's the start, that you need to have dentistry and medicine, you know, working
Right.
together hand in hand, because again, it boils back down to patient care and, you know, keeping people out of pain and keeping people healthy and not having other diseases, you know, that correlate or get aggravated by, you know, periodontal disease, for an example. So I liked a lot of the things that you guys were talking about today as far as different things that can be done. And yeah, there are some challenges in every industry and
Sure.
with dental insurance, but it also sounds like there's a lot of people out there who are looking to find ways to provide better care and to figure out how it's a business. You know, our dentists and our practices need to be compensated. But I want to give you guys a chance if there's any closing comments that I haven't covered in a very broad generalization of what you said tonight. Alyssa, is there anything else that you would want to share on your thoughts on this whole issue?
No, I mean, I think we covered a lot of ground, and we could probably talk about this all day because it's what we do all day and the things we deal with. But it's nice to be, you know, a hygienist and a dentist and having the conversation and realizing that we're really all on the same page and our goal is the same, to provide care to our patients, and we got to figure out how to do that with or without, you know, dental insurances, but we got to figure out how to work together. So
Yeah. I would say that we owe it to our patients. You know, the people that we're talking about here, especially in this last little segment, we've been talking about, you know, telehealth and skilled nursing facilities and such. You know, these are the people that everybody refers to as the greatest generation. And I think the greatest generation now needs the greatest compassion that we can provide them. I mean, they did amazing things to get all of us to this point. The least we can do is take care of them in return.
100% agree.
Couldn't say it any better than that. Well, thank you both for joining me tonight. And it's always been a fascinating conversation every time I've been on these calls with you guys. So,
Well, thank you. Thank you
Yeah,
for
thanks for
facilitating.
having
It's always
us.
a good time. Thank you guys very much.